I have some ladies that are like, I love my testosterone when it's a 200. I'm like, I'd be one big pimple if it was 200. So I'm not going to do that.
There's a thing, we talk about menopause being a thing. Some people don't believe in andropause, but it is a thing too.
Thyroid hormones, my God, use thyroid hormone replacement if you need it, and use bioidentical replacement because we all need that.
Welcome back to another episode of the Smarter, Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Sherr, and it's a pleasure to be back with all of you. It is so fun to host this podcast. I get to talk to so many amazing clinicians, typically, that are doing amazing things in clinical care. And today, with no exception, I spoke to Dr. Amie Hornaman today. Here's a little bit of a bio on Amie. So she has her doctorate in clinical nutrition and is a leading functional medicine expert in thyroid conditions, hormone dysfunction, and weight issues. She has her own podcast. It's a top-rated podcast called the Thyroid-Fixer, and her own supplement line as well. And it was just an amazing time speaking to Amie. And she is just a wealth of knowledge on the thyroid gland as the master gland, as she says many times during this podcast. We initially began speaking about how thyroid physiology works, various types of thyroid hormone, TSH, and the various things that block thyroid hormone from working, like our bromide and our fluoride and others that are all around us at all times. I even found out that pastries have bromide. I didn't know that. That was new to me. So we spoke about that. Then we talk about how you can do a full thyroid panel on your patients and what you're looking to interpret and things like reverse T3 and why that's important. We also had a nice conversation about T2, which is also a very new topic for me, and how you can supplement with T2 potentially and prevent TSH suppression and also prevent the breakdown of lean body mass. And that was pretty cool too. We talked about her work in weightlifting and bodybuilding back in the day and how they were using T2 and T3 and various things that may be good, may be not so good, depending on what you're looking to do. We then transitioned over to talk about how we can work on optimizing thyroid hormone and how Amie very rarely uses T4, actually never uses T4 on its own. We talked also about the fears that clinicians like me have prescribing thyroid replacement and how many of these things are misguided depending on what you're worried about, like bone loss, like cardiovascular issues. These are things that you have to think about. But if you're doing them in a holistic way, in a hormone optimization way, then you don't have anything to worry about most of the time. We also spoke about testosterone in women and how this is protective for autoimmunity as well. Finally, we ended up speaking about the ways that Amie lives a life smarter, not harder, and recommends all of us, including her work with sleep, a very challenging one for Amie overall. So anyway, I really hope you enjoyed this podcast with Dr. Amie Hornaman. She was a fantastic guest. We learned a lot. I learned a lot. I hope you do too. Now, if you like our podcast, don't forget to like and subscribe below so you never miss an episode, and share with your friends and family. Have a great day. Enjoy. All right. Dr. Amie Hornaman, how are you today?
I'm doing great, Scott. Thanks for having me on.
It's a pleasure to be here. Thank you for having me on your podcast not too long ago too, and getting to spread the word about all the things that we do. But I'm excited to have you on to talk about all the things that you are doing so well in the world and working with a particular endocrine gland that is somewhat misunderstood by the conventional community. Would that be a slight, nice way of saying it? Maybe. So,
Yes, that's a very nice way of saying it. Yes, I agree.
I thought so too. Yeah. And so what I want to start off with here is that, as you know, we're talking before we started recording, like many people that are listening here are physicians or clinicians that are looking at thyroid function. They're looking at optimization and various strategies. But I thought we could do a quick refresher for everybody, including me, on thyroid physiology. So understanding, thyroid hormone production, soup to nuts, talking about hormone signaling, talking about production of the thyroid hormones. I'll let you take it from here because you do this all the time.
Yep.
And then we'll just kind of wrap and figure out navigation ways to go.
Yeah, for sure. So even like you and I were talking about off camera, expanding into the functional integrative world, not just the conventional medicine world, I see a huge lack of love on the thyroid. I almost want to encourage clinicians to really go back and remember that the thyroid is the master gland. And I don't even think it gets enough love in medical school. I know it doesn't. So going
Definitely.
back and remembering that the thyroid is the master gland and has such immense control over every system in the body. So we can look at the cardiovascular system. Yes, it controls heart rate, it controls blood pressure, it controls our body temperature, it controls our GI tract, our GI motility, really determining whether or not we're going to poop every day. It controls the brain because there's thyroid receptor sites on the brain. So memory, cognition, focus, muscle contractions, metabolism, mitochondria function. It has control over every aspect of the body. And if that's the case, then why aren't we paying more attention to it? Why aren't we
Mm,
focused on that as a root cause? I'll hear this from my
mm,
patients like, well, what's the root cause of my thyroid problem? Okay, yeah, we can say that we can go down and say it's autoimmune thyroiditis, it's Hashimoto's what caused that autoimmune condition, Epstein-Barr virus, toxins, whatever. But what is the root cause of your weight gain, your fatigue, you think you have early onset Alzheimer's, you're not going to the bathroom every day. The root cause of those symptoms is the thyroid or insulin signaling being off, glucose control being off despite the perfect diet,
mm,
thyroid. Because when we look at the thyroid, okay, let's go backwards. It's the HPT axis, hypothalamus pituitary thyroid axis. So when we're looking at something like TSH, which is a standard test that everybody runs to check thyroid function, we have to remember that is a pituitary hormone that is released from the pituitary to signal the thyroid.
mm,
And the way I don't want to say dumb it down, but analogize it into saying it's like, like a feeler, like a blind person with a stick, like going out there going, hey, what's around me? What's around me? So the pituitary is sensing all the time. It's measuring, it's temperature control. Is there enough thyroid hormone in the body to do the job? Yes. Okay, then we can be quiet. So then TSH will be lower. And we'll get to suppress TSH when we start talking about treatment and fears and all that. So the TSH will be even optimal in the functional world. Optimal will be below a 2. If there is not enough thyroid hormone in the body, the pituitary starts screaming at the thyroid gland, hey, bud, you're not doing your job. Come on, come on, come on. Let's wake up and produce some thyroid hormone. Then that's where we see TSH go up.
mm.
But we can't rely on TSH alone. I mean, that's the basic physiology, but we can't just hang our hats on TSH alone and think that that's a predictor or even a diagnostic tool, honestly, unless it is screaming, unless it's
Mm.
crazy high, unless it's above that 4.5 conventional cutoff in the standard lab value range. Then we can say, oh, yeah, you know what, there's a problem here. But
Mhm.
what if it's low? Does low mean hyper? No, because it is a pituitary hormone. We
Right.
have to go down and look at the thyroid hormones, which measurable are the T4 and the T3, total and free. And we have to look at those to see, is this person's thyroid gland producing enough and doing its job, producing enough thyroid hormone? And then we go
Mhm,
into, the optimal ranges for those, which we can talk about.
mhm,
We also have to look at reverse T3. And when we're talking about the physiology of the thyroid, but also the physiology of the entire body, we know that reverse T3 is a beautiful built-in survival mechanism. We need it. We want it. When you're in an accident, when you're in trauma, when you're in a viral load state or whatever it is, when your body is trying to heal, reverse T3 will go up. And many clinicians will say, to patients, we only test reverse T3 in a clinical setting. Right. Because we hope that it's high in a
mm,
clinical setting. We hope if you're
mm.
laying in the ICU that reverse T3 has gone up because as you're fighting for your life or trying to heal a traumatic injury, you don't need to burn fat. You don't need to feel good. You don't need to think. You don't even need to poop every day. You need for all of the body's energy to be shuttled toward healing. The
Right.
reason why we wanna test it in a non-clinical setting or in just an average everyday setting on a patient is because we wanna see if they're in survival mode walking around trying to live life, and
Yeah.
that
So
is
what yeah, yeah,
entirely
yeah,
possible to
yeah,
have happen. So,
yeah, yeah.
yeah, that's kinda the overview, but we can get more
Right. So,
granular from there.
yeah, for sure. Let's stick with T3 for a minute.
Mhm.
Reverse T3, excuse me. So, what is you talked about survival mode. You talked about T3 reverse T3 going up. talk a little bit about what reverse T3 actually is, where it is, and what is its function.
So this is very much debated in the medical community, especially the way that I describe it to the general population, to
Mm,
listeners of my podcast, my patients, whatever. I describe it as a bouncer at the club, that it reverse T3 is elevated and it stands outside the cell door and blocks T3 from getting in. Now, I've heard arguments that no, it does not block it. But anecdotally, when I look at someone's labs, oftentimes when that reverse T3, I won't see it so much. Okay, wait, let me back up. Reverse T3 optimal is below a 12 in
okay.
functional medicine. I'll accept less than 15 if the free T3 is optimal and the patient is symptom free.
Okay.
I won't see this I'll use this term very lightly, pooling effect of T3 unless the reverse is really high, like 20, 24 or above, actually flagged high. What you'll see is a free T3 of a really good, if not kind of elevated number. We'll
Mm,
get like a 3.7, a 4.2, and the patient has a boatload of symptoms. And my only explanation for that, I mean, short of looking inside their body, is that reverse is so high, their own T3 or the T3 that they are on is in the blood. It's getting picked up on serum. We see it. It's actually optimal on the labs, but it's not connecting to that receptor site on the cell because every one of our cells has a receptor site on it for T3, heart, brain, skeletal, everything. So it's not connecting at that cell level to turn the switch, to turn it on.
gotcha.
Yeah.
Okay. So if your reverse T3 then is elevated, at least in a clinical setting, we do know that this is a survival mechanism, though.
Mhm.
That's for sure.
Right.
Okay, got it. And so when you're talking about thyroid hormone in general, how do we make our thyroid hormones? Like, where does it come from as far as like what amino acids, or what is the pathway that our body takes to make thyroid hormone?
So the thyroid gland produces T4 and T3. It also produces T1 and T2, which we can talk about, but we can break this down. T1 is inactive. We can just kind of set that aside.
Okay.
T2 and T3 are very active. We only have currently assays for T3. They do have tests for T2 in the studies, but not for the general population, not yet at least. And then we know that T4 is inactive as well. And the reason we have the 2, the 3, the 4, those are iodine atoms attached. So we have to go through a process of, and I can never say this word properly, deiodinization. Basically,
Nicely
the
done. Yeah.
T4 has to lose one of the molecules to become and transform into T3. That's why iodine is so vital.
Mm,
Now, amino acids, I haven't seen a boatload of studies on you need these amino acids in order to produce thyroid hormone, but we know that when we look anecdotally as well at, let's take a vegetarian or a vegan, and we look at their thyroid function, it's low. So we know amino acids play a role. Like we know that
mm,
they are needed. I've just never seen, I couldn't tell you which ones, like how we know, leucine is vital for building muscle
sure.
and all of that.
Sure.
I'm not sure which ones, but I can tell you from seeing thousands of patients over the years, the animal-based protein people, the non-vegan vegetarian, usually have better numbers to start, even if they are in a Hashimoto or hypothyroid state, and they absolutely respond better to treatment. But the minerals that are necessary, we know hands down, iodine, selenium, magnesium is needed to convert T4 to T3.
Yes.
And really without those, you're gonna be at a loss. You may have an elevated reverse T3 just from iodine deficiency. Let's say you might have a person that doesn't have an elevated reverse T3, but they just don't seem to be responding to thyroid hormone treatment. That could be low iodine. It might not show up in the reverse right away, but they're having some conversion issues because there's not enough iodine in the system, or bromide, chlorine, and fluoride are taking the place and attaching to the receptor site where iodine should be and
Yes.
causing a toxic overload to where, nothing can work. The cell can't work when it has a toxic halogen attached to it.
Mm. Yeah. Thank you for mentioning that on the mineral side. So fluoride has been pretty well described as something that blocks the iodine receptor. Is that right?
Yep, those 3 halides. So, and even bromide, I mean, we don't think about it unless we're thinking Mountain Dew. If you looked at a
Yeah.
bottle of Mountain Dew, there it is, right? And
Where are our
brominated in
sources?
red.
Where are our sources of bromide? Do you know some sources of that other than Mountain Dew?
Our clothes, dry cleaning, furniture, carpets. If you live near a golf course, that's what they spray on it. If you have an
Really?
old school hot tub, you're soaking in bromide. Yeah. Yeah. And then all the conventional pastry products.
Conventional pastry products
Oh,
also.
yeah.
They're,
Yeah.
they're bromadized. I didn't know that.
Yeah.
So fluoride, we know. Are there any other sources of fluoride other than typically found in toothpaste? Right? I mean,
Toothpaste. Yeah. And then well, our water system. So our government decided to put fluoride in our water to try to prevent cavities. And we know, I mean, you talk to a biological dentist, if any of them are listening on here, speak up. It's like, no, fluoride does not prevent cavities. There's no need. And I'm sure you remember, Scott, at least I did. I did the little pink pills when I was little, and you'd be all pumped out because you look in the mirror and your teeth are all pink and you got that from the dentist fluoride treatment. And all we were doing is toxifying our thyroid gland, which is inches
yeah.
away from our mouth.
Yeah. And I just had Nathan Bryant on the call on the podcast just recently, and we were talking about how that depletes completely your nitric oxide supply because it kills all the bacteria in your mouth that produce nitric oxide. And so not only are you screwing up your thyroid, you're also screwing up your nitric oxide supply, and that's kind of a big deal too.
Right.
So very interesting. Yeah. I mean, so we have all these processes that are happening to convert our T4 to T3. And when it comes to T2 and T3, let's talk a little bit about T2. So you can't measure T2, but what do we think the role of T2 is compared to T3?
It's really coming up in the literature more and more these days. I think we still need more actually randomized clinical trials done with humans. Because I'm only in all of my research over 15 years of T2, I've only ever seen 2 human studies done. Both of them resulted in very powerful results, very powerful outcomes to where we see an improvement in lipid panels, an improvement in insulin sensitivity, and most potently is the increase in basal metabolic rate without it having an effect on the cardiovascular system or being thyromimetic. It's not going to change someone's thyroid labs
Interesting.
to make
Okay.
them appear hyper, where their conventional doc would freak out, be like, oh my God, you're
Right.
hyperthyroid. T2 doesn't do that, but it does provide a really nice relief from symptoms that patients present with, such as the inability to lose weight, they're gaining weight no matter what they're doing, how they're eating, as much, however much they exercise, doesn't matter. They're still putting on the pounds. And then that crushing fatigue. So the other cool thing about T2 is that it works at the mitochondrial level to stimulate ATP. It browns fat. So it literally stimulates that brown adipose tissue that we tell everybody to jump in a cold plunge to do. It stimulates that brown adipose tissue that ties back to the improved insulin sensitivity and of course, increased metabolic rate. It's very, very potent, very powerful. And I'll give you a quick little story that kind of drives the point home. Anyone that knows a bodybuilder or a fitness or figure competitor, or even from back in the day, you will know that the bodybuilders were the OGs of biohacking. Like I was in that world back in my 20s, right? I can tell you that we tried everything on ourselves before it came into the Ben Greenfield space, right?
Definitely.
So T2, I mean, admittedly, whether you like it or not, bodybuilders and competitors, fitness and figure competitors, male, female, would abuse T3 in order to get lean for a show. And when you talk to, I heard a pro, so there's the pro division, amateur and pro. When you talk to a pro trainer, like he's trained the best of the best, I heard him interviewed and he says, I don't let my athletes use T3 because here's the thing. Number one, T3 will burn body fat. It'll increase the metabolism, but it'll also burn muscle. It doesn't differentiate between the two. And that's the last thing you want to do as a competitor is lose muscle. I mean, that's the last thing any of us want to do because muscle is so metabolically active, protects everything. So he goes, the other issue is they're also going to come out the other side of that competition with a thyroid problem because of the negative feedback loop that occurs. We talk about the pituitary
Yep.
You take T3 and you don't need it. Now you're sending that message back to the pituitary where the pituitary says, okay, thyroid, you don't have to produce anything. We're good. There's enough thyroid hormone in the system. Just stop working. Just lay down and go to sleep. And that's what happens. And then the person comes off the T3 and it's like, ooh, I'm gaining 40 pounds in a month. I wonder what happened. Well, you shut down your own thyroid function. Now, if you
Yeah.
need it, you need it. That's a whole different topic.
Right.
But if you don't need it, you're going to shut down your own. So he says, I use T2
Mm.
because it's not going to produce a thyroid problem. They're not going to come out the other end of the show and all of a sudden need to be on thyroid medication where they didn't before. And it's also only going to burn body fat and not burn their muscle. So
That's good.
I mean, it really is an incredible hormone. And I think it needs a lot more love and attention and research.
Yeah, it sounds like it. I mean, you're totally right about bodybuilders. I mean, we know about this from like Russia in the 80s, right? Everything they would throw at these people at their weightlifters and bodybuilders and somehow got diffused into bodybuilding culture. I guess even earlier than that, like in the 50s and 60s
Mhm.
probably. So definitely, I mean, what's interesting about this is that it doesn't suppress TSH, which is very interesting to me. And then also, does it seem like you have to actually wean off of it when you stop the T2 or you can just stop it?
You can just stop it. Yeah.
Wow.
I mean,
You don't have any rebound effect.
no, none
Wow.
at all. Yeah.
Wow, at least so clinically, this is what you're seeing, right? I mean, it hasn't been studied in these ways at this point, is what it sounds like. So clinically, you're seeing patients and you're not having to wean them off the T2. They can just stop it and they're good.
Absolutely. Right. They can
Yeah,
just stop it. Now, obviously, you want to take it until you get to your goal weight. And then, like any kind of weight loss protocol, no matter what you're doing, you want to control your food intake. So if you go off of it and you start eating like garbage again, you're going to gain the weight. You might need to throw it back in. Or I'll have patients that they reach their goal weight and they'll keep it on hand to take like when they are on vacation, they know they're going to be eating more around the holidays, or they'll take it on the weekend or something like that. They'll use it intermittently just to keep that basal metabolic rate up and running.
it's so interesting. Okay. Yeah, T2 sounds like sort of the new frontier, or at least a frontier that I haven't explored at all with my patients yet at this point. Um, so let's move over to talking about testing. So obviously we can't test for T2, but tell me how you think about. We talked a little bit about reverse T3 already, but tell me how you think about like a full, thyroid panel. Like if you were going to keep teaching a physician or a clinician, this is a full thyroid panel. Let's go through that, and then let's go through how you would think about the levels of all these types of things, normals, optimals, those kinds of things.
Right. 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 Okay. So we know TSH. That's hands down.
Right.
All of us are going to test that. And free T4 is usually thrown in there as well. But with free T4, it's important to note that we're not going for a super high level of free T4. In fact, that's not usually a bad sign. So if I'm looking at someone's free T4 level and it is, let's say a 1.6, 1.7, I go, oh no, the reverse is going to be high because that marker we really kind of want in that like 1 to 1.5 range, unless someone is on T3 only, which we'll get to in treatment. But if someone's on T3 only, then naturally the free T4 is going to drop. We don't chase numbers. We pair numbers with the person's symptoms and really personalize treatment. So it's not about chasing numbers unless we're talking about reverse T3. And then we do kind of chase numbers. So we want that less than 12, but we don't care if it's suppressed. I get that question from clinicians a lot. Like, do we care if reverse T3 is suppressed? Usually no. Because if a person is on T3 only, or if they're on more T3 than they are T4, you're kind of changing that ratio because they need
Mm,
that ratio to be different. They need more T3 than they do T4. Maybe they have conversion issues, or you just know, listen, if I give this person more than 25 micrograms of T4, the reverse is going up to a 20. You've already seen it happen. You've already experimented. You just know. So that person is naturally going to have a lower free T4 and you don't care because you want to keep that reverse below a 12. Then we go on to free T3, and that's another one that we really care about. Free T3, we want in the upper quadrant of the range. Now, that varies from lab to lab, and
mhm.
then you have to get personalized and individualized again. If I have had patients that have a free T3 not in the upper quadrant of the range, let's use LabCorp, it goes up to 4.4. Someone comes in with a free T3 of a 3.1, but they feel amazing. How do you feel? Oh my gosh, I've never felt better. I'm finally losing weight. I'm not gaining weight looking sideways at a brownie. I have energy through the day. I'm not taking a nap at 2 p.m. and I'm going to the bathroom every day and my hair's coming back. Woo! Do we chase that number and give him more T3? No, we just leave him right there. We pair it up. But at the same time, you could have someone else with the exact same labs, free T3 coming in at a 3.1. And they're like, I can't, I'm so tired. And I just gained 5 pounds last week. And okay, now you increase their T3 to get that more in the upper quadrant of the range or over. I want to say that too, or
Mm,
over, because
mm,
someone's optimal might not be like Susie's optimal, might not be Jane's optimal, right? Susie
right.
might need her free T3 to be a 4.4 to feel her best. And Jane might be totally fine at a 3.1. So we want to look at the optimal range. We pretty much know if you're coming in the bottom half of the range that you're going to feel like garbage and have symptoms.
Mm,
But at the same time, we really want to personalize it and pair it up with how they feel.
cool.
And then there's the antibodies. The
Yes.
antibodies.
Yeah.
Yeah.
Let's go through those. Yeah.
TPO, thyroperoxidase, and thyroglobulin antibodies. We always want to test. And again, that standard lab value range will have, depending on the lab, it'll have, less than 34, or less than 9, or less than whatever. Ultimately, you want them at 0. I always argue the point of, well, I don't have Hashimoto's because my TPO antibodies are a 20 and the lab says it has to be less than 34. Yeah, except you have 20 antibodies that are going out and attacking your thyroid gland and you have a boatload of symptoms. So
Mm.
are we just going to hang out and wait until you hit 34 antibodies and then say, hey, you have Hashimoto's now?
That's what conventional
No,
medicine would do, right?
right, exactly.
Yeah.
Exactly. Wait and see, watch and wait. So no, I would address that immediately and try to reduce the antibodies, LDN, black cumin seed oil, gluten-free, all of the lifestyle things, like
Mm,
sleep,
mhm,
cortisol. And then at the same time, I'm going to look at their thyroid labs and their symptoms and go, we might have to implement thyroid hormone replacement here.
mm. Got it. And that goes along with the other antibodies as well?
The TGA, yeah. Normally we'll see TPO raise in Hashimoto's, but I test both.
Mhm.
Thyroglobulin antibodies can be an indicator of thyroid cancer, but not always. And sometimes I will see positive thyroglobulin without positive TPO, which is not usually the case, but sometimes you might see that as well. Same thing. You just, yes, go ahead and send them for an ultrasound, confirm it,
Right. Right.
make sure that they don't have any nodules that need biopsied or anything like that. But you can still look at any presence of any antibody as a red flag. You don't wanna ignore it.
Yeah. That's what I was kind of driving at too, I thought. So you already alluded to this, and I love that you made this this jump that very difficult for conventional medicine doctors to do, which is how does my patient feel?
Mm. Yeah.
and and not just think about what's in the normal range versus not. And so do you have a sense of how these laboratory companies create their normal ranges as far as if you had a LabCorp and you're getting a range that you said the top level is around 4.5, do you know what kind of sample they're using to get those kinds of numbers or no?
I mean, everything I've heard, and we've heard
Yeah,
this, kinda ad nauseum in this space, is it's taken from a group of sick people. So
exactly. Yes,
right, and that's the huge
exactly.
problem of it.
Yes. Yeah, that's what I've heard too.
Right.
And yeah. So, I mean, I've also heard that they take a TSH level, for example, from somebody that's maybe 18 to 95, and then they average those out. Yeah, I'm sure you have this conversation with people all the time. I'm always like, well, do you want to have in this case a TSH level of a 75-year-old when you are not 75, or if you're 75, would you rather have a TSH of a 22-year-old?
Exactly, exactly, and that's where functional medicine comes in, and that's how we get our optimal lab value ranges, because we're taking, even if we do test a 75-year-old, we're testing the one that looks like a badass, has muscles, has stamina, has flexibility, doesn't look their age. Like, yeah, let's test that person because they're doing something right. That's where you want to land. It's that bullseye optimal range where we say this is where we believe that you will feel your best, and then the one step above that is how do you feel?
Yeah, I love that because that's the key is that, and you can't just always be chasing numbers with your clients. You have to be chasing how they feel because it could be, you get me a great story earlier about two people with the same T3 levels, one feeling terrible, one feeling amazing. And it just depends on what else is going on and looking at things in totality. Okay. So we've gone through like the numbers, at least the levels of things that you're going to check. Now, when you're looking to replace somebody's thyroid hormone or optimize thyroid hormone levels in various ways using this testing, what kinds of products? I mean, you talked about T2 a little bit already, but like other than T2, which sounds like it's amazing overall, and I have to try it. The T3, T4, how are you replacing these? Are you ever using just T4? Let's go through this and see what
Right.
rolls.
Never use just T4. So there is a stat that I heard at A4M, and I even challenged the stat. So let me give it to you first. 2% of the population do well on T4 monotherapy. 98% need a combination of T4 and T3 or T3 only. My argument is, of that 2%, I would like to talk to them and ask them how they're feeling.
How many people are, because the percentage of people that are just on T4 is like, it must be gigantic
huge
compared to,
right.
Yeah.
Right. And there's the flip side is then if we actually look at the percentage of hypothyroid patients on T4 monotherapy, probably is around 98%. And then 2% are on the T4, T3 combo or T3 only.
Yeah, that's
and
right.
Yeah, we need to flip that. But even of those 2%, like I don't know where A4M got these stats. I mean, I grabbed onto it because I thought, ooh, that's really interesting. Yes, I believe in the 98%, but I would even go so far as to say 100, because give me those 2% of people that claim they're doing well, air quotes, on T4 only. Are they overweight? Are they tired? I was on a plane sitting next to a woman, you start talking and, what do you do? What do you do? She goes, oh yeah, I have a thyroid problem. What are you on? Oh, I'm on Synthroid. I'm doing really well. Well, I'm sorry. She was at least 50 pounds overweight. Her hair was incredibly thin. She was missing the outer corner of her eyebrow, which is why I asked. I'm like, all right, I'm going to get curious here. And that was her norm. Like her new norm was, I'm okay, but you could be better. You could be so much better. So I truly believe that anyone with a thyroid problem, if you're not catching it early and they actually need thyroid hormone replacement, you have to use T4 and T3. Now, I'll expand a little bit on that because I also see this belief system permeate integrative and functional and alternative medicine that we have to use NDT, Armour and P thyroid to treat. And that's it because it's natural. Well, I hear this from my patients too. And I say to them, it's made by a drug company in a factory. Like it's not just a bunch of farmers bringing their desiccated pig thyroid gland to encapsulate it for you. It's made by a drug company. There are fillers in it. Yes, it's desiccated pig thyroid gland, but there are many Hashimoto patients that don't do well on NDT. And we have to go into treatment knowing that and being willing to really personalize thyroid treatment because it is nuanced. There is no one size fits all, despite what you've been taught. There's no one size fits all ever in any patient. So you have to be willing to really look at the numbers and look at that person as an individual and personalize the treatment. And if that means using what I call the biosynth, so they're not synthetic. Let's not use that term because it's going to scare the patient anyways. The biosynth, the levo, the synthroid, the tyrosint, the cytomel, the liothyronine. Let's use
right, the
those.
T3 of those two.
Yeah, the T4, the T3 separately. Let's use those to really personalize the treatment. I am T3 only. I take nothing but liothyronine, generic. I do great on it. I'm 75 micrograms twice a day. It's a relatively high dose. Yep. If you looked at my numbers, a normal doctor would freak out. They would say I was hyper, and they would pull my T3. Now, if you pull my T3, which I've tried because we all experiment on ourselves, I will gain 10 pounds in a week and I will become depressed.
Wow.
If you give me T4, 25 micrograms, I will gain 10 pounds in a week and I will become depressed. So,
even if you're still taking T3?
Yeah, because I don't convert at all. I don't convert. So I have a D101, D102 gene, which I finally tested recently and it is confirmed. But yeah, I don't convert at all.
Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, pharmaceutical-grade, and physician-formulated formulas in the form of a buccal troche. Check out for this episode Tro-Z. Tro-Z is our complete sleep solution. It'll help you feel sleepy, fall asleep with ease, stay asleep. If you do wake up, though, you'll be able to fall asleep easy because you have Tro-Z on board and then wake up feeling rested. It has 8 different ingredients in there, working on all 8 stages of your sleep, improving the architecture of your sleep at the same time. Go to transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. Can you talk about
So
that gene for a minute? I'm not familiar with that one.
D101, D102, it's not like on a 23andMe. Even DNA company doesn't test for this. This was done. I have an epigenetic health coach that works for me, and she has her own company. It was called a Purion before. I forget what it's called
Yep.
now.
I know who you're talking about. Yep.
Okay. So they
Mhm.
actually tested it because I'm like, I want this tested. I want to know because I've been on T3 only for 20 years. Like, and she's like, she tested it and confirmed it. So it's a SNP that impairs conversion. You can have
Mm,
one SNP, two SNPs, you can have both, whatever. But it tells us that you may not be a very good converter of T4 to T3.
got it. So if you're having somebody that comes in and you wanted to start replacing their thyroid hormone, what would you start off with typically in this case?
You
Would it
froze again.
be
You froze
okay?
again. You'll have to repeat that.
It's okay, no
Sorry.
problem. So if you have somebody coming in and they need thyroid hormone, okay, what is your original or what's your initial way of approaching it overall?
Approaching like the medication doses.
Yeah. So what do you start off with, like as far as dosing and strategy overall?
Yeah. So, oh gosh, that's so nuanced too. So it depends
Yeah.
if the person comes in. Let's say your typical hypothyroid patient, been through the conventional system, they're on T4 only. So they come in. Now we have to look at the reverse T3. If
Mm,
reverse T3 is high, let's reduce the dose of T4, especially if they're on. You see everybody 112, 125, 150, these higher doses of T4. Let's pull that back. And then let's add in some T3 and see how they do. And I always start with 5 micrograms twice a day, just gradually titrating up, building that up. And then we can retest and see, did the reverse come down? Did the free come up? And how are their symptoms? And adjust from there. I mean, same thing if someone comes in on NDT medication. Yeah, they're getting a little bit of T3, but darn, that reverse T3 is still high.
mm,
Let's drop that dose, see how they do with a little bit of lower dose of NDT, and let's add in T3 because we can do that. We can
mm,
customize and personalize treatment. It doesn't have to be either NDT or the biosynth. It can be a blend of. So you can add T3 to the NDT to again change the ratio. NDT is 80% T4, 20% T3. So if we want to change that ratio to help the person lower their reverse and increase their free T3, then we can do that. And then it just really becomes more personalized from there. I mean, if
mhm.
someone's brand spanking new, they're not on any medication, they've had a thyroid problem for a while. They've known about it. Nobody's diagnosed it because that's a huge issue as well, just misdiagnoses. And then they come in and then, again, it's about looking at those numbers. Like, can we start
Right.
on NDT here? Oh, the reverse is pretty low. Okay, let's start you on 30 megs of armor twice a day, maybe working our way up to 60, and then let's retest and see how you do. And in that retest, that's where you'll see how their body responds to it.
Mm. That makes a lot of sense. I mean, as you know very well from all your experience, and certainly I do too, that you really just have to do something differently for almost every patient when it comes down to. You can start off with the same kind of framework and say, this is the framework that you're going to start with. This is where we want you to go. But getting from point A to point Z can take a long way and be lots of circuitous kinds of derailments along the way.
Right.
Um, yeah, one thing you mentioned earlier that I also wanted to go back to is that if we can catch it early, sometimes we don't need thyroid hormone. And so, can you speak to that a little bit? What you mean by that?
Those usually are not the patients coming to me,
I would
but
imagine. Yeah.
but it is possible that you will see people that you are catching things early to where you're looking at the labs and you're going, wow, these are really, really close to optimal. And, they just have the issue of low energy and they're not gaining weight. They're not trying to lose. They're okay there. But we can see the start of Hashimoto's and we can start to see those thyroid hormone levels dropping and maybe the
Mm,
TSH climbing a little bit. This would be like your TSH is a 3 and your free T3 is a, 2.9. And so at that point in time, you can go, okay, maybe if we just give iodine, that's a great place to start. You need
mhm,
iodine to convert, you need iodine to make thyroid hormone, give iodine.
mhm,
Maybe we add in black cumin seed oil to lower the Hashimoto antibodies. Make sure that they're taking mag and selenium. Make sure their vitamin D level is good. Um, And then maybe even bring in some of the bioregulators, kind of going back to like what you were saying about the Russians starting it first, right? They were using
Damn right.
bioregulators a
Yeah.
long time ago
Yep.
before we were. So you can bring in thyroidogen as a thyroid bioregulator.
Mhm.
You can bring in an adrenal bioregulator and then see how they do. And maybe that will be enough to keep them off of thyroid medication. But at the same time, I also urge practitioners and even urge patients to shift the way that they look at thyroid medication and put it in the category of hormone replacement because that's what we're doing. We're replacing hormones that are no longer being made by your body. And I understand some people's goal is to not take a written prescription that they pick up at Walgreens. They want everything compounded or they want to take supplements. That's fine, that's great if we can do it. But if we can't do it, so I'll always use the example of a type 1 diabetic with insulin. If your
Right.
kid has type 1 diabetes and your doc says they need insulin, you're not gonna be like, yeah, no, we're not gonna do that because
Yeah.
they'll die, right? You're
Yes.
not gonna do that. But it is a hormone. Insulin's a hormone. When we need to replace hormones, we do it because in my opinion, quality of life, we only have a certain number of days on this earth. Let's live it to the utmost and feel good while we're here. Quality of life is so much more important than you having to pick something up at Walgreens. Like, get over that ego thing. Just stop. Put thyroid hormone replacement in the category of bioidentical hormone replacement.
And why shouldn't it be, right? It is a hormone that we need to replace. And that actually just kind of I thought of a question. Is there such thing as, we talk about andropause, that is a thing. We talk about menopause being a thing. Some people don't believe in andropause, but it is a thing too.
Mhm.
Is there such a thing as thyropause where the thyroid does naturally decline in function with age as well?
Yes. I believe Sarah Gottfried was the first one to coin that
Okay.
term. I believe I want to give credit where credit is due, but I'm not positive. But I have used it since because whoever said it first is right. There is this shift, and we kind of know now why. So when we're looking at hypothyroidism, we know that 95% of hypo is Hashimoto's. We know that one big trigger, because there was a study for this where they gave men with Hashimoto's thyroiditis who had low testosterone levels, they gave them TRT and their antibodies dropped and thyroid function improved. So we know
Mm,
that the reason why women get hit harder with Hashimoto's than men is because testosterone is very protective against autoimmune and women just have less T overall. Now add on top of that age. And we know that progesterone really is the hormone that goes first in a woman's sometimes 20s, 30s. Testosterone follows, followed by estradiol. So as that testosterone starts to drop, and testosterone takes over as the most abundant hormone in menopause, unless we're replacing all the hormones like we should be. But
mhm,
testosterone levels in general will start to drop, and that's just enough for that Hashimoto switch to turn on. If it didn't
mm,
turn on during pregnancy, which is also a hormonal stressor, it
absolutely.
it can turn on when our hormones start to shift in perimenopause and menopause.
Mm. So women have a higher risk because they have lower testosterone than men then.
Yes. I mean, listen, we're all at risk because of the toxins in our environment
Right. Right.
and everything that we're being bombarded with and nutrient depletion of the soil and nutrient depletion of everything. But yes, in general, when we look at testosterone, it's incredibly protective against autoimmune.
Mm. And so when you're thinking about hormone replacement in a female, in this case, when they're coming in, say they have hypothyroidism and you're looking at some of these hormones, what is your go-to as far as how you replace how you replace testosterone, estrogen? Do you have a specific, what's your framework here for thinking about it?
Well, it depends. I mean, I love
Yeah, of
using
course.
BHRT. It's
Yeah.
just the delivery method is what changes. So with
Gotcha.
estradiol, I like the patch, I like creams, no oral because that increases SHBG, and then that has been shown in some studies to be a little bit of a higher risk of causing cancer, stroke, blood
Hmm.
clots. And then
Hmm.
with progesterone, we'll do cream or oral, depending on
Hmm.
the person's tolerance and their symptoms paired up with it. And then testosterone, cream, injectable, troche.
Mm.
The reason I put troches last, and yes, we can use troches for estradiol and progesterone as well. The reason why I put troches last for testosterone is because some of it is swallowed, and we know that it kind of pounds the liver a little bit. So we'll see elevated liver enzymes and
Oh,
just
wait. Okay.
more of a stressor. So if we can do The cream, if it works, now cream will convert more to dihydrotestosterone. So when you have the ladies on the cream, you might hear a lot of complaints about the hair, chin growth, and some acne and some hair loss or hair thinning.
Mhm.
Injectable, while it seems so scary and it seems like, oh, that's something only a man does.
Mm.
With women, we're microdosing 10 milligrams, 20 milligrams, 30 milligrams a week max. And they're just doing it sub-Q and they
Just like a
tolerate it
weekly
really
dose,
well.
or
Yeah,
typically
just
is it
once a week.
done once a week? Yeah. So, I mean, I know that in men, it seems to be ideal to do at least twice a week as far as injections.
Yeah.
They used to do like the 9-week shot and just bludgeon men with like a huge dose, and then they just decline for 9 weeks and then back again, like
Ugh,
craziness.
it's horrible.
So for women, is it pretty steady using like a once a week kind of dosing?
Yeah, that's fine. I mean, if we have a woman, like I do 10 milligrams a week. I have some ladies that are like, I love my testosterone when it's a 200. I'm like, I'd be one big pimple if it was 200. So I'm not going to do that. But if they're doing like 20 milligrams a week, we can split that up. I can say, yeah, just do 10 twice a week. But if you're doing something as minuscule as 10, I mean, it's hard enough getting that,
I know it's a small amount. Yeah, it's a
this
small
teeny
amount.
tiny amount. So
Yeah.
yeah, I'll
Yeah.
just do once a week. And that seems to be just enough to keep levels steady.
And so you've seen this in clinical practice where you started this kind of hormone replacement and then you've seen antibodies just go away or significantly decline?
Well, it's hard for me to say in clinical practice because we're doing all the things at once. So it's like,
Sure.
was it the
Sure.
chicken or the egg? Was it the black
Sure.
cumin seed, the LDN, the testosterone, or the thyroid
Right.
hormone replacement, and the
the-
iodine?
That's the thing about working integrative practice, right? You're not just working at one thing and you're doing all these things. And that's why it's so difficult to quote unquote prove the things that we do work, because everything is done in such a huge context with diet, lifestyle, supplements,
Right.
medications, and everything else in between. Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners on how to optimize health rather than treat disease, the root cause of health, not the root cause of illness. For this particular episode, check out the Exposomics module, where we talk about toxins in our environment, how they affect our endocrine glands, including our thyroid gland that we discuss with Amie in this podcast. Go to homehope.org and save 10% on your order or any module of our certification by using code podcast10 at checkout. Now back to the show.
Exactly.
I have a question for you now, Amie, if you can hear me.
Mhm.
You got me?
Yes.
Okay. So question here is, I wanted to do, we talked about this offline before we started, is let's talk about the fears that a lot of practitioners have, because the thyroid, the TSH, looking at T4, T3, let's kind of run through some of the major ones that you find in clinical practice that you kind of have to work through with providers, and let's take them and just let's dispel them. Let's do it.
Absolutely. So what I've run into with some of the functional practitioners that I've collabed with on patients is they have this fear. I don't even know where it develops, where they have a cap to how much T3 they'll give, but I've heard this a couple times. Like, I won't go above 10 micrograms or 10 micrograms twice a day. And I say, well, what if someone needs it? I mean, that's like saying, we're going to give you 50 milligrams of progesterone and that's it. It's too bad, too sad if you need more. No, you have to have an open mind to personalize what that patient needs. And I do have a very unsupported hypothesis that seems to ring true in 95% of the cases. Your type A drivers, your entrepreneurs, your athletes, your driven people, the crazy drivens need more. And it would make sense because we have receptor sites on our brain for T3, everywhere in our body for T3. So that would make sense that those driven individuals, active, always thinking, using their brain, active in their body, need more T3 than, let's say, someone sitting at a desk and just doing the 95 and going, I mean, not that there's anything wrong with that, but this is what I see in practice, that those
Totally.
individuals need more, and you have to be open to that. And then the fears that come with increasing the dose, bone loss, and then the cardiovascular effects. So we'll break each one down. Bone loss, as I've said, I am on 75 micrograms twice a day. I have been for around 20 some years. And I just finally got a DEXA last year at KetoCon, and my bones are as strong as anything. And no, I don't take calcium. I take vitamin D, I take magnesium, I do weight-bearing exercise, and
Yes.
I take estrogen and progesterone. Oh, and
Of course.
testosterone. So all of the
Yes, all of them.
the hormones and the
Yeah,
nutrients
you need
and the
them. Yeah.
minerals and the exercise keeps my bone. Now, if I didn't do any of that, would T3 have an effect? There are some studies from the past, we'll say older studies that do show a suppressed TSH can cause, loss of a bone. But then I've also seen some recently, and I couldn't find it to save my life. I'd have to do a deep search. But recently that kind of ixnayed that whole thought process. Like, oh yeah, what we were saying before about the low TSH, not so much. Because if you think about what do we do post-thyroid cancer? We work to suppress the TSH to prevent tissue regrowth. Why
Mm,
is it safe to do in post-thyroidectomy patients who had cancer and it's not safe to do in the general population? Like, that doesn't,
mm,
with hypothyroidism, that doesn't even make sense. Why would we do it with one and not the other? Like, are we saying
mm,
to the cancer patients, like, it's okay if you have a heart attack and osteoporosis, but we just want to keep this TSH suppressed? Like, no. So that's number one, would be the bone. And
mm.
there are things that we can do to counteract that. Yes, I'm
Right.
sure if you had a very sedentary individual that didn't take care of themselves and you give them high amounts of T3, would we see some bone loss? Possibly, but could we correlate it back to the T3 and the TSH, or could we correlate it back to their shitty lifestyle? I don't know. It depends.
Hmm. Hmm.
Um, but then, okay, let's move on to the cardiovascular. We also know that AFib, SVTs, those can actually be tied back to a non-optimized thyroid. And one of my patients actually one of my employees that was a patient previously, she was diagnosed with AFib and had an ablation prior to coming into the practice and getting her thyroid optimized. She was on T4 only. And now she can clearly look back and say, like, it was the thyroid. It was the thyroid. My husband ended up in the hospital with SVT. And, I'm texting my colleagues and they're like, now, just as a reminder, since you can't think for yourself, make sure to check his thyroid. I'm like, yes, that's right. Yes, I will tell them to do the full thyroid panel. Thank you, because that's such an underlying causative factor of those cardiovascular conditions. Now, listen, when you start someone on T3, can they get an increased heart rate? Can they have increased blood pressure? Yes, and then you always have
Hmm.
to go back and check, because I'll get the message, my heart rate is increased, and I go, what is it? Check your watch. Check your monitor. Oh,
Hmm.
well, it's 75. I'm like, right, because you're normal now. And you were used to being at a heart rate of 55, and you weren't Lance Armstrong. You were just hypothyroid with a really low and slow heart rate. And
Right.
now you're into, normal mode and you think that it's increased. And at the same time, though, you will get the people that are like, I'm 130 sitting at my desk.
Mm.
Like, okay,
That's not good.
let's roll it back then. Let's decrease your thyroid rate because it is increasing your heart rate too much too quickly. Maybe we went up too high too quickly and we just have to roll it back and things will settle. So it's about monitoring
Right.
and tracking the patient and guiding them properly in their dosing. That's all.
So, do you typically, when you start something like T3, will you have them watch their heart rate pretty closely when they first start it?
Yep. Heart rate. Sometimes we'll do, especially if they're just starting on T3, we'll do the whole vital sign check, like take your body temp, take your heart rate, take your blood pressure. We want to see all of those go up, actually. Like that's our goal, and that tells us that we're on the right track. But
Right.
when you're looking at your heart rate, yes. I mean, if it is increasing too high and it's too high for the situation at hand, if you're exercising, it goes to 130, okay. But if you're sitting at your desk and it's been an hour and you're like, "Ooh, have that 130," then that's an indicator that we need to change the dose.
Makes sense. Okay. Any more fears that you have to dispel here, or you've kind of covered the most?
Those are the two big ones. The
Yeah.
cardiovascular and the bone loss are the two big ones, and then just the mental block on increasing, which I'm sure ties back to those other fears. And
Right.
then, of course, the suppressed TSH, which is tied to both of them, but we don't have to worry about it. In fact, some people don't even test, some functional docs don't even test TSH on retests
Mm.
because they know it's gonna be low, so why even test it? I mean, I'll always throw it in, but I'll ultimately, even yesterday, I got a message from a patient, "Well, I'm really concerned about my TSH being low." I'm like, "Have you not heard the 5 different podcasts I have on not worrying about the low TSH?" But okay, let's go over this. So, yeah,
Gotcha.
yeah.
Okay. Cool. Well, this has been a great tour de force on thyroid function, Amie. I really appreciate your time. I have one question for you last. This is the question we ask everybody at the end of the podcast, which is, how can we live smarter, not harder? You can give it 3 ways. It could be thyroid related. It could be absolutely not related to that, of course, whatever
Mhm.
you choose. We have busy lives, all of us, and some of us are in the middle of the country, like you in Iowa and me in Colorado. And others in the East Coast and the West Coast and all over the world. And what can we do in your estimation?
Okay. Well, smarter, not harder. Number
Yeah.
one, is going to pull in the thyroid hormones. My God, use thyroid hormone replacement if you need it, and
Mm,
use bioidentical replacement because we all need that. I am a firm believer that we can all benefit because of the studies and everything on longevity and prevention of disease and quality of life. And oh my God, from bioidentical hormones. And we're not going to out exercise, out sleep, out biohack hormones declining. I mean, you can for a little while, but ultimately we're all aging. We're not aging like Benjamin Button. So we're going to have to replace those hormones. I think that is a beautiful way to live smarter, not harder, because it makes things easier and it keeps people off of the band-aid medications.
hmm
Number 2 would be, and this isn't possible for everybody, but I think you and I can speak to it, is find a place to live that gives you peace. And because you're in your environment, whether you work from home or not, we live, breathe, sleep, and eat in our location, in our home, in our town, in our wherever the home is plopped.
hmm
So to your best extent, make that be peaceful. Get your surroundings down so that you can wake up and go, "Ah, okay, no matter what happens today, I'm really happy. I'm cool. This is awesome." Because your environment will absolutely give you peace and make your life
Love it.
easier.
Love it.
Number 3, so I have suffered I used to suffer with sleep issues. I shared this with when we were talking about the True Z. So, and I did try it the other night, I'll tell you. Um, so I've suffered with sleep issues since I was 25, and I was on either a benzo or Benadryl or Tylenol PM or something until really about 8 years ago, and finally kind of corrected that. One of the things that I have found that really, 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 really helps is the stupid blue light blocking glasses. You hear about it all the damn time, but then you finally put them on and you actually use them every night. Oh my God, you produce more melatonin. It actually kind of works, right? So, I would always kind of cover my ears when people would talk about the importance of sleep because I don't want to hear it because I don't sleep well and I don't want to know and I don't want to know. But we have to look at sleep and we have to admit that that is such a cornerstone for everything, for how your brain works and diseases and insulin control and glucose control and everything, recovery, the whole deal. So we have to be sleeping. So using, something like blue light blocking glasses and then so the Truzies. So we talked the other day and I'm like, okay, I'm gonna try. So my concoction that got me off the benzos is Delta 8 and then just a combo of melatonin, 5-HTP, a little valerian root, that kind of thing. So I stack that together. So I said to you, Scott, I'm like, I'm gonna use Truzy and Trozy or Truzy. Am I saying that right?
Trozy, close enough.
Trozy.
Yeah. Yeah.
And I'm gonna use that instead of my Delta 8s, and I'm gonna see what happens. So I took a half the other night. Damn, I slept well. It worked
Amazing.
really, really well. So I'm a believer now. So I messaged the one patient that I had that we tried everything on. I'm like, you gotta get this. You have to get this and try it because it works. So yeah, I mean, sleep. Sleep would be number 3. Do what you
I
have to
love it.
do naturally, minus the benzos and the whatever ambience to sleep.
Yeah, sleep is the big one. And Dr. Ted, who I work with at Transcriptions, like to say that your day doesn't start when you wake up, it actually starts when you go to bed. If you think about it that way, you can think of how important it truly is. But Amie, thanks so much for being here. Where can we find out more about you, about the work that you're doing? You have a supplement company too, making some great things. Let us know.
Yeah, so with all the work that I did studying T2, yes, I came up with it's a fixer supplement line and it's the flagship product called Thyroid-Fixer. Can we use it on individuals that don't have a thyroid problem, that just want to burn fat and improve their metabolism and improve their ATP production? Yes, you can. Because that contains the 3,5-diotyl-L-threonine or T2. So that's Thyroid-Fixer. And then we talked a little bit about black cumin seed oil that's in Hashimoto's Fixer, but I have that full line. And so you can go to betterlifedoctor.com and see that entire line, the Fixer line. And then if you just want to connect with me, dramihornaman.com is my site. And I'm on all social media as Dr. Amie Hornaman as well.
Sweet. Well, Amie, I hope I get to see you sometime soon again in person. Thanks so much again for being here. Have a
Thanks,
great
Scott.
day. Thanks so much for tuning in to another episode of the Smarter, Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. And Dr. Amie had many of them today on thyroid, on understanding thyroid physiology, thyroid function, thyroid testing, thyroid replacement, testosterone replacement, toxins in our environment, and so much more. If you like this podcast, please don't forget to like and subscribe below so you never miss an episode. We'll see you next time on the Smarter, Not Harder podcast.